Imagine you're 45 years old. You've just spent the entire weekend helping a friend move.
Oh boy, we've all been there.
Right. So you're lifting heavy boxes, you're wrestling a sleeper sofa up 3 flights of stairs, you're sweating, and maybe you're holding it in because, you don't want to ask to use their bathroom every single hour.
Yeah, you just want to get the job done.
Exactly. But on Monday morning, you wake up and you are hit with agonizing, highly localized pelvic pain. I mean, it is severe.
That sounds absolutely terrifying.
It is. So you go to the doctor.
Wow.
You're sitting on that crinkly paper on the exam table in obvious distress.
Right.
The doctor walks in, takes one look at your chart, looks at the location of your pain, and without asking a single question about your weekend, your heavy lifting, or your bathroom habits, they implicitly accuse you of having a secret affair.
Wow. Just jumping straight to that conclusion.
Yeah. They write you a prescription, they hand you a pamphlet on sexually transmitted infections, and they walk right out the door.
It sounds like a complete medical nightmare. But honestly, statistically speaking, it happens every single day.
And it happens because the medical system is just absolutely saturated with default assumptions.
It really is.
So, welcome to the Deep Dive. Today, we are looking directly at you, the listener, and we are unpacking a fascinating and honestly highly misunderstood corner of urology, which is epididymitis.
Specifically, we're diving into the data surrounding the non-STD causes of this condition.
Yes, but let me be clear right out of the gate. This isn't just some dry anatomy lesson about localized inflammation.
No, not at all.
We are using this specific, often highly stigmatized condition as a magnifying glass. We want to look at how medical assumptions break down, how real-world patient misunderstandings delay critical care, and ultimately how independent medical platforms like iMedix and sophisticated drug databases are changing the way we interact with the actual pills we swallow.
It's a huge topic.
It is. Okay, let's unpack this, because the question at the center of all this research, which is, can you get epididymitis without having an STD? Well, it unravels a massive web of assumptions we make about our own bodies.
You know, what's really fascinating here is how quickly a purely physiological symptom gets wrapped in all these layers of societal assumption.
Right, and psychological dread.
Exactly. When we talk about epididymitis, the anatomy and the pathology are undeniably complex. But the real story, the thing we really need to focus on, is the profound communication breakdown between the clinic and the patient.
It's basically a perfect case study in medical literacy.
It really is. I mean, in an age where information is literally in our pockets, true, actionable understanding of our own health risks and medication safety is just remarkably scarce.
So to get that understanding, I want to start with the geography of the problem, because it seems like the stigma is entirely geographic.
That's a great way to put it.
The epididymis is located in the scrotum, right? Resting at the back of each testicle. And because of where it's located, the human brain, and honestly, often the clinical brain, immediately jumps to, well, it's down there, so it must be a sexually transmitted infection.
Exactly. The geographical location of the anatomy sort of dictates the societal stigma of the disease.
Right.
But let's look at what the epididymis actually is, because the biological mechanics dictate why it's so incredibly vulnerable to non-STD issues in the first place.
Okay, lay on me.
So it is not just a simple tube. It is a tightly coiled microscopic structure.
Like a spring.
Sort of. But if you were to uncoil it, it would be nearly 20 feet long.
Wait, 20 feet packed into the back of a single testicle.
Yes, it's a massive surface area condensed into an incredibly small space.
That is wild. What does it actually do with all that space?
Its primary function is basically a staging ground. Sperm are produced to the testes, but they are completely immature.
Okay.
They can't swim, they can't fertilize an egg. They pushed into this 20-foot microscopic hallway of the epididymis, and it actually takes them up to 2 weeks to travel through it.
2 weeks just to get through the hallway.
Right. And during that really slow journey, they interact with specialized proteins and they mature.
So it's like a really long microscopic training camp.
Exactly.
Yeah.
Now, think about the physics of a 20-foot microscopic tube. It is incredibly delicate.
I would imagine so.
If anything introduces inflammation to that environment, which, by the way, is the itis in epididymitis, the swelling has literally nowhere to go.
Because it's all packed in so tightly.
Right. It causes rapid, severe pain, localized swelling, and sometimes even a systemic fever.
And when that happens, the default assumption from almost everyone is chlamydia or gonorrhea.
Almost always.
The patient immediately thinks, oh man, I have an STD. And the psychological weight of that distinction is just immense for the listener.
It's a huge burden.
If a patient automatically links their pain to an STD, it creates this immediate, massive barrier of shame. It can lead to completely unfounded anxieties about a partner's fidelity. I mean, it destroys trust.
And medically speaking, the absolute worst part of that shame is that it causes a patient to delay seeking care.
Because they're scared.
Exactly. They are terrified of the judgment they anticipate at the clinic. They don't want to have that awkward conversation with a doctor or a nurse.
Yeah, nobody wants to feel judged when they're in pain.
Right. But beyond the stigma, acknowledging non-STD causes isn't just a matter of being polite to the patient. It's a matter of sheer clinical accuracy.
Because if you just assume it's an STD, you completely stop looking for the actual root cause.
You put blinders on?
Let me try an analogy here because I think we've all been in a situation where dread sort of paralyzes us.
Okay, let's hear it.
Think of it like seeing a check engine light pop up on your car's dashboard.
The dreaded light.
The worst. Let's say you've had a really bad history with cars, so you immediately, automatically assume the entire engine block is destroyed.
Oh, sure. You jump to the worst case scenario.
Right. You assume it's going to cost $5,000, that you somehow ruined the car by driving it wrong, and it's entirely your fault.
So you panic.
Yeah. Out of pure debilitating dread, you just ignore it. You keep driving with that red light glaring at you every day.
Which is terrible for the car.
Exactly. When in reality, the issue might just be a loose gas cap messing with the oxygen sensors.
A completely benign issue.
Right. But the symptom, the light, triggers a worst-case, highly stigmatized assumption that literally stops you from fixing the actual easily solvable problem.
That is a remarkably apt comparison. I love that.
Thanks.
A loose gas cap in this scenario could be a simple, common urinary tract infection, which, as the data clearly shows, is a highly frequent cause of non-STD epididymitis.
But because the patient is terrified of the blown engine?
The STD diagnosis and all the social fallout that comes with it.
Right. They don't even pull into the mechanic shop until the damage is severe.
Exactly. And the delay is where the real medical danger lies.
I was looking into the medical side of this, specifically the demographic breakdown, and it honestly blew my mind how sharply the data pivots based on age.
It's a very clear dividing line.
It really is. If we're looking at men under the age of 35, sexually transmitted infections really are the most common cause. Chlamydia and gonorrhea are the heavy hitters there.
That is statistically accurate, yes.
But the moment you cross that 35-year-old threshold, the entire paradigm just completely flips.
It absolutely does.
In older demographics, the most common causes are entirely non-sexually transmitted. So walk me through the plumbing of that. What is actually happening in a 45 or 50-year-old man's body that introduces inflammation into a 20-foot microscopic coil?
Well, it almost entirely comes down to the dynamics of the urinary tract and the prostate.
Okay, the prostate.
Yes. As men age, it is incredibly common for the prostate gland to slowly enlarge. This is a condition known as benign prostatic hyperplasia, or BPH.
Benign, so it's not cancer.
Correct. It's just a normal part of aging for many men. Now, the prostate sits right below the bladder, and it surrounds the urethra like a donut.
Right.
So as it enlarges, the hole in the donut shrinks. It literally pinches the urethra.
Oh, like stepping on a garden hose.
Exactly like stepping on a hose. And because of that constriction, when an older man urinates, the bladder has to work much, much harder to push the fluid out.
And I'm guessing it doesn't always succeed.
That's exactly the problem. Often it doesn't completely empty. You are left with residual stagnant urine just sitting there in the bladder.
Uh-oh.
Yeah. Now, stagnant fluid anywhere in the human body is a big problem. It becomes a perfect, warm, nutrient-rich breeding ground for bacteria.
Like a swamp.
Pretty much. Particularly enteric bacteria like E. coli, which naturally migrate from the GI tract to the perineum.
Okay, but wait. How does the bacteria get from the bladder all the way down into the testicle? That seems like a pretty long journey for a microbe.
It is a long journey, but bacteria are incredibly sophisticated. E. coli isn't just floating aimlessly around hoping to get somewhere.
It's got a plan.
It has biological tools. It has little hair-like appendages called pili that allow it to anchor to the walls of the urinary tract.
So it grabs on.
Yes, and it actually builds a protective shield called a biofilm. It's very similar to the plaque you get on your teeth.
Oh, wow. So it builds its own armor.
Exactly. And that armor makes it highly resistant to the body's natural immune response.
That's crazy.
Once it establishes a colony in that stagnant bladder urine, it begins to travel backward. This is what we call a retrograde infection.
Retrograde, meaning it's going the wrong way down a one-way street.
You got it. It swims against the current, down the vas deferens, which is the tube that transports sperm, and it settles right into that delicate, tightly coiled environment of the epididymis.
And once it gets there,
Well, once there, the immune system finally detects it and launches a massive inflammatory counterattack, and suddenly you have acute epididymitis.
and all of it triggered simply because the prostate got a little larger with age.
All of it.
That is just wild. An enlarged prostate, which is just a standard mundane part of aging for millions of men, creates this plumbing bottleneck,
Right.
which then breeds a bacterial biofilm, which climbs backward into the reproductive system.
That is the exact mechanism.
And if a doctor doesn't ask about urinary flow, if they just assume STD right off the bat, they completely miss the prostate issue entirely.
Exactly. And they miss the chance to treat the underlying cause. And the medical reasoning goes even deeper when we look at mechanical interventions.
What do you mean by mechanical interventions?
Take catheter use, for example.
Oh, okay.
If a patient is in the hospital for a completely unrelated surgery, say a knee replacement, and they require a urinary catheter.
Right, pretty standard procedure.
Yes,
Okay.
but that physical tube provides a literal highway for bacteria to completely bypass the body's natural external defenses.
Because it's holding the door open.
Exactly. The bacteria form a biofilm directly on the synthetic material of the catheter itself. They travel up into the urinary tract and, again, take that retrograde path down the vas deferens.
Okay, so we have bacteria or stagnant urine, and we have bacteria introduced by medical equipment. But what about the guy I mentioned in the intro?
The guy moving the sofa.
Yeah. The 45-year-old moving heavy boxes. The research calls it chemical epididymitis, which honestly sounds intense.
It is intense.
How does lifting a couch cause testicular inflammation? There's no bacteria involved there, right?
There doesn't have to be. This is one of the most fascinating mechanisms, and it relies entirely on hydrostatic pressure.
Hydrostatic pressure. Okay, break that down for me.
Remember, the urinary system and the reproductive system share a pathway in men, the urethra.
Right.
When you engage in heavy lifting, intense physical exertion, or even a really severe bout of coughing, you are dramatically increasing your intra-abdominal pressure.
Oh,
This is clinically called the Valsalva maneuver. You are bearing down.
right, like when you're tightening the cord to lift something heavy.
Yes. Now imagine you are doing that while you have a completely full bladder.
Like our guy who didn't want to use his friend's bathroom.
Exactly. That massive spike in intra-abdominal pressure basically squeezes the bladder like a water balloon.
Oh, man. I can see where this is going.
The downward pressure forces urine into the urethra. But if the pressure is high enough, it can actually overcome the small, delicate sphincter valves that normally keep fluids flowing in only one direction.
So the one-way street fails.
It fails. The sheer hydrostatic force pushes a jet of urine backward, shooting it down the vas deferens and directly into the epididymis.
But wait, if there's no bacteria in the urine, like if it's completely sterile urine, why does it cause inflammation?
Because urine is essentially a highly concentrated waste product.
Oh, right.
It is full of urea, uric acid, and various salts. It is naturally highly acidic.
Okay.
The tissue lining the bladder is specially designed to handle that acidity.
But the epididymis isn't.
Not at all. The microscopic, extremely delicate tissue lining the inside of the epididymis is absolutely not equipped for that.
So it's like throwing acid on a sensitive surface?
Yes, when that acidic urine blasts into the epididymis, it acts literally like a chemical burn. The tissue sustains acute chemical trauma. And the body reacts exactly as it would to a bacterial infection. It sends a massive flood of white blood cells, fluid, and inflammatory markers to the area to repair the damage.
So the patient experiences the exact same excruciating pain, swelling, and redness as a bacterial infection.
The exact same, but there is not a single microbe involved.
So just to recap this for the listener, because it's wild, you can get a swollen, agonizing epididymis just by lifting a heavy box with a full bladder.
Yes.
Because the physics of your abdomen literally shot an acidic chemical burn into your reproductive tract.
Precisely. That is the exact physiological reality.
And yet, if that man goes to a rush clinic and the medical professional doesn't thoroughly evaluate his history...
If they don't sit down and ask, hey, have you been doing any heavy lifting? Did you hold your urine all day?
Right. If they skip that, they are just going to throw a blanket STD diagnosis at him.
They absolutely will.
This highlights the massive gap between what patients think is happening and the actual medical reality. Let's visualize this for a second. I always picture the human brain trying to sort symptoms into neat little boxes. On the left side, we have what I think is happening.
the perception.
Right. And because of the internet, that box isn't empty. It's usually filled with actively incorrect, terrifying information.
Usually the worst-case scenario.
Exactly.
Yeah.
Then on the right side, we have the actual medical mechanism. The left side says, I have a shameful infection.
And the right side says, your prostate is pinching your urethra.
Right. Or you lifted a couch weird.
Exactly. And the space between those two boxes, that gap, is a void where danger, severe anxiety, and delayed care reside.
And I imagine that's why proper clinical evaluation is so critical.
It is the most critical step. We have to move beyond just looking at the symptom and jumping to a geographical assumption.
So what does a proper evaluation look like?
Well, a good urologist doesn't just guess. They look at the mechanisms. They will run a urinalysis and a urine culture.
To see what's actually in there.
Exactly, to actually identify if there is bacteria and specifically what kind of bacteria. Is it E. coli from the gut, or is it Neisseria gonorrhea from a sexual encounter?
They need the data. And they use ultrasound too, right? I read that's a major part of the diagnostic puzzle.
Yes, very importantly, a Doppler ultrasound.
What's the difference between a regular ultrasound and a Doppler?
A Doppler maps blood flow in real time. You can actually see the blood moving through the tissue.
Oh, cool. Why is that so important for this?
This is crucial for ruling out a true medical emergency, which is testicular torsion.
Torsion. That sounds bad.
It is. Torsion is when the testicle literally twists on the spermatic cord, completely cutting off its own blood supply.
Oh, man.
It presents with the exact same sudden, severe pain as epididymitis. The patient can't tell the difference.
But the ultrasound can.
Instantly. In torsion, the Doppler shows zero blood flow to the testicle. It's completely dark on the screen.
Because it's choked off.
Right. But in epididymitis, the Doppler shows a massive increase in blood flow. It lights up like a Christmas tree because the body is furiously pumping blood to the area to fight the inflammation.
Okay, so think about what this all means for you, the listener. Let's say you're that 50-year-old man. You're experiencing these symptoms, but you know you don't fit the stereotypical profile of a sexually transmitted disease.
Right. You haven't been with a new partner in 20 years.
Exactly. Because the societal narrative only gives you the STD option, you might think, well, it logically can't be that, so it must be nothing. I pulled a muscle. I'll just wait it out.
Which is a very dangerous assumption.
How often do we do this with other aspects of our health? We brush off glaring, flashing warning signs because we don't fit the expected stereotyped profile of the disease.
We do it constantly. Human nature loves a pattern, and when we don't fit it, we ignore the data. And the public health implications of this specific misunderstanding are just staggering.
Because they're letting it get worse.
Right. If an older patient actively excludes themselves from the affected group because they view the condition as purely lifestyle-driven, they allow a non-STD cause to silently worsen.
And what happens if that E. coli infection just sits there?
It doesn't just stay there. If left untreated, the bacteria can continue to spread. It can enter the bloodstream to cause sepsis, which is life-threatening.
Oh.
Or it can travel further up the urinary tract to cause a severe kidney infection. The misunderstanding isn't just an inconvenience, It is a direct threat to the patient's life.
Which perfectly illustrates why we desperately need an antidote to this misinformation.
We absolutely do.
The individual needs access to reliable, structured data. They need to realize that their heavy lifting, or their aging prostate, or their recent hospital stay are the actual culprits here.
They need context.
And when you look at the research and the tools being developed to combat this, the conversation immediately shifts to independent medical platforms, specifically platforms like iMedix, which focus on rigorous patient education.
Right. If we connect this to the bigger picture, platforms like iMedix represent a fundamental shift in how we manage the medical narrative.
Okay, how so?
Well, we really need to define what independent actually means in the context of modern healthcare, because everyone on the internet claims to be unbiased.
That's true. Every website has a little badge that says trusted or independent.
They do. It's just marketing.
Yeah.
But true structural independence means the information architecture is entirely decoupled from pharmaceutical marketing.
Meaning they aren't trying to push a specific pill.
Exactly. It means the platform isn't designed to sell you a specific brand of medication. Furthermore, it is entirely separated from the rushed, high-pressure environment of the modern clinical visit.
Which is a huge factor.
Huge. In a standard setting, a primary care doctor is incredibly pressed for time. They might have 12 patients in the waiting room right now.
So they're rushing.
They have to. They diagnose the epididymitis, they hand over a prescription for a broad-spectrum antibiotic, and they move on to the next room.
Leaving the patient kind of bewildered?
Right. The patient is left holding a piece of paper, swirling with anxiety, realizing they forgot to ask a dozen vital questions. And they have absolutely no idea what the pill they are about to take actually does to their body.
They're just following orders blindly.
Exactly. Independent platforms exist to fill that massive, dangerous void. They focus on providing the deep medical reasoning and answering the complex treatment questions that inevitably arise at 11:00 p.m. when the clinic is closed.
But I have to push back here.
Sure, go ahead.
Because, honestly, this is where my own brain gets stuck. Aren't independent platforms just going to make our collective hypochondria significantly worse?
What do you mean?
Well, if I have pelvic pain and I jump on the internet, usually within 4 clicks, I'm reading an anecdotal horror story on a random forum that convinces me I have a rare, incurable flesh-eating disease.
That is a very common experience, yes.
Right. So how does a platform like iMedix actually differ from just typing epididymitis into a random search bar and descending into a panic spiral? Aren't we just giving people enough data to terrify themselves out of taking the treatment they actually need?
That is a brilliant pushback, and the distinction you are highlighting is exactly the difference between unstructured anxiety and structured empowerment.
Unstructured anxiety versus structured empowerment, like that.
Your fear of the late-night internet rabbit hole is entirely valid. The open web is completely flooded with anecdotal, emotionally charged, and structurally chaotic health content.
It's the Wild West.
It is. A forum gives you a stranger's worst-case scenario with zero medical context.
Right. I took this pill and my hair fell out and my dog ran away.
Exactly. It's just noise. It's unverified noise. The key difference with an independent platform like iMedix lies in the architecture of verified data.
So it's not forums.
Not at all. We are talking about platforms built directly on rigorous clinical trial safety data, official FDA regulations, and deeply verified, continuously updated drug databases.
Okay, so it's actual science.
An independent medical platform doesn't give you anecdotes. It gives you statistical reality, physiological mechanisms, and verified safety protocols. It organizes the chaos into a navigable map.
Okay, let's put that map to the test.
Let's do it.
Let's look at the actual treatments for non-STD epididymitis, because positive thinking isn't going to clear an E. coli biofilm out of your reproductive tract.
No, it certainly will not.
You need medications. Specifically, you need heavy-duty antibiotics.
You do. And this brings us to the critical realm of medication safety and really understanding the regulatory context.
Which people usually ignore.
Completely.
Yeah.
Taking medication isn't just about reading the label, take one pill every 12 hours with water and assuming the problem is magically solved.
Right.
It is about understanding the specific biochemical interaction that drug is going to have with your unique physiological makeup.
So what does that look like in practice for our 50-year-old epididymitis patient with an E. coli infection?
Let's examine the standard protocol. If the cause is a non-STD enteric organism, the first-line treatment for decades has frequently been a powerful class of antibiotics, known as fluoroquinolones.
Fluoroquinolones, okay.
You might recognize the specific drug names. Ciprofloxacin, which is commonly called Cipro or levofloxacin.
Oh, yeah, I've definitely heard of Cipro.
Most people have. Now, these are incredibly effective drugs. They're essentially the nuclear option for bacterial infections.
The nuclear option. That sounds like there's a serious catch. Let's get into the mechanism. How do fluoroquinolones actually kill the bacteria, and why is it considered the nuclear option?
To understand the risk, you really have to understand how brilliantly aggressive the drug is.
Okay, break it down.
Bacteria, like all living things, need to replicate their DNA to survive and multiply.
Sure.
When bacterial DNA is packed inside the cell, it is twisted and coiled incredibly tightly.
Kind of like the epididymis itself.
Exactly. Now, in order to copy it, an enzyme called DNA gyrase comes in, acts like a pair of biochemical scissors, cuts the DNA, untangles it, and then pastes it back together.
So it's managing the DNA replication?
Right. Fluoroquinolones work by binding directly to that DNA gyrase. They basically jam the scissors.
Oh, wow.
The enzyme cuts the bacterial DNA, but it cannot paste it back together. So the bacteria's own DNA is shattered into pieces, and the cell rapidly dies.
That is ruthless. It literally weaponizes the bacteria's own replication machinery against itself.
It is highly, highly effective. But here is the catch, and this is exactly where independent drug databases become vital.
What's the catch?
Fluoroquinolones don't just stay in the urinary tract. They saturate the entire body. And while they're designed to target bacterial enzymes, they actually have systemic off-target effects on human tissue.
Off-target effects? That doesn't sound good.
It's not. Specifically, they have been shown to upregulate enzymes in the human body called matrix metalloproteinases, or MMPs.
Okay, MMPs, what do they do?
MMPs are enzymes that degrade collagen, and collagen is the primary structural protein in your body. It is the fundamental building block of your tendons, your ligaments, and your cartilage.
Let me use an analogy here because I think I'm getting this.
Go for it.
Think of collagen as the steel rebar hidden inside a poured concrete pillar.
Perfect.
The concrete looks solid from the outside, but it's the steel rebar inside that actually gives it the tensile strength to hold up a bridge. Are you saying these antibiotics accidentally trigger enzymes that start eating away at the steel rebar inside my tendons?
That is precisely what the medical data shows.
Wow.
And it happens rapidly. Because of this collagen degradation, fluoroquinolones carry a significant, sometimes severe risk of tendinitis and actual tendon rupture.
Rupture, like it just breaks.
Yes. The Achilles tendon is the most commonly affected. Patients have literally been walking down the stairs completely normally, and their Achilles tendon just violently snaps.
From an antibiotic.
Yes. The drug also carries risks for peripheral neuropathy, which is permanent nerve damage, and severe interactions with other common medications.
Like what?
Like basic antacids that can bind to the drug in the stomach, or certain heart rhythm medications that can trigger fatal arrhythmias when combined with Cipro.
This is terrifying. If I'm taking a drug that can literally snap my Achilles tendon, why wouldn't the doctor spend 20 minutes explaining that to me?
Because of the systemic pressure we discussed earlier. The 15-minute clinical visit.
They just don't have time.
They don't. The doctor knows that the immediate threat is the E. coli infection, destroying your epididymis and potentially moving to your kidneys.
Right, sepsis is the immediate danger.
Exactly. So they weigh the statistical risk of the tendon rupture against the absolute certainty of the infection, and they write the prescription. But the patient is entirely left out of that risk-benefit analysis.
They don't even know there's a risk to weigh.
Exactly. Which is exactly why accessing an independent drug database on a platform like iMedix is so critical. The database doesn't just say, take this for your infection.
It gives you the whole picture.
It provides the surrounding ecosystem of what that specific chemical does to human tissue. It illuminates the regulatory context.
Yes, the regulatory context is key here. Regulatory agencies like the FDA don't just ignore these risks, right?
No, they don't. Over the years, as the data mounted regarding tendon ruptures and nerve damage, the FDA actually issued multiple black box warnings for fluoroquinolones.
Okay, a black box warning. I've definitely heard that term, but what does it actually mean physically in the medical world?
It is the strictest warning put in the labeling of prescription drugs by the FDA. It's used when there is reasonable evidence of an association with a serious life-threatening hazard.
So it's literal.
Very literal. It is a warning printed inside a thick black border on the drug insert. It is the FDA basically yelling, pay attention, this can cause severe, irreversible harm.
But patients never see that box.
Almost never.
When I go to the pharmacy, they hand me an orange plastic bottle with my name on it and a tiny little sticker that says, like, take with food. The actual paper insert with the black box warning gets thrown in the trash by the pharmacist, or it's folded up like origami and stapled to a receipt that I immediately recycle.
That is exactly the problem. When a doctor prescribes a treatment based on a specific regulatory context, the patient rarely gets to see the behind-the-scenes decision-making process.
They're shielded from it.
And they almost never see the actual regulatory warnings. They are entirely removed from the safety loop.
Oh.
By accessing an independent database, the patient can finally see those black box warnings for themselves, front and center.
They see the regulatory guardrails.
Yes. They are no longer flying blind.
Let me throw one last analogy at you.
I love the analogies. Let's hear it.
Taking a powerful prescription drug without understanding its mechanism, its side effects, and its regulatory warning context is exactly like being dropped into the driver's seat of a high-performance sports car in the middle of a massive, chaotic foreign city that you've never visited.
You're completely lost.
Right. The warning context, the information rigorously stored in these independent databases, represents the stop signs, the speed limits, the one-way street indicators, and the hazard signs for washed-out bridges.
Okay, I see where you're going.
You can technically put the car in drive and just mash the gas pedal, meaning you can just blindly swallow the medication, but you desperately need the GPS map and the rules of the road to know where the hidden dangers are. Platforms like iMedix provide that GPS map.
That is spot on. It is the map, the compass, and the local guide all rolled into one, and without it, honestly, you are bound to crash eventually.
And what does that crash look like?
That crash might be a severe adverse drug reaction, like a ruptured Achilles tendon, or it might be a mismanaged condition because you allowed a non-STD infection to spread due to the stigma of an incorrect assumption.
And if we're successfully using these tools to compare similar drugs or situations, does that mean a patient might actually discover a safer, more effective alternative just by taking the time to understand the data?
Yes, absolutely.
Because earlier I asked if this would make people refuse treatment entirely out of fear. But if they can look at the database and say, okay, Cipro is the nuclear option and it might hurt my tendons, is there a different option? That feels like a literal superpower for the listener.
It absolutely is a superpower.
Yeah.
And it counters your earlier worry about hypochondria perfectly.
How so?
Well, let's go back to our 50-year-old patient. He reads the database. He sees the black box warning for fluoroquinolones. He also knows he is an avid runner, making his Achilles tendons highly, highly vulnerable.
So he's at higher risk.
Right. Armed with this structured information, he doesn't just refuse treatment and let the infection spread to his kidneys. He returns to his doctor and says, "Given my specific risk profile and activity level, the fluoroquinolone warning concerns me. I've looked at the alternatives in the drug database. Can we use a cephalosporin antibiotic or perhaps a sulfonamide-like Bactrim, which might be slightly less aggressive but carries a significantly lower risk of tendon rupture?"
That is incredibly specific. And what does the doctor say to that?
Honestly, a good doctor will be thrilled.
Really? They won't be annoyed.
A good one won't.
Hmm.
Because that is what true patient empowerment actually looks like. It moves healthcare from a paternalistic dictatorship, where the doctor just hands down orders from on high, to a true collaborative partnership.
That's amazing.
When a patient can say, "I understand the non-STD mechanical cause of my diagnosis, I understand the mechanism of my infection, and I have rigorously reviewed the regulatory warnings and alternatives for the proposed treatment," they have essentially mastered their own medical destiny.
Which brings us to the end of an incredibly dense, fascinating journey today.
We covered a lot of ground.
We really did. We have synthesized a massive amount of medical and pharmacological reality. We started with a highly misunderstood, geographically stigmatized diagnosis, epididymitis. We broke down the revelation that non-STD pauses are not just possible, but honestly incredibly prevalent. We explored the deep anatomical mechanisms of why an aging prostate, an enlarged bladder, or the simple physics of lifting a heavy box can force bacteria or sterile acidic urine backward into the reproductive tract, completely mimicking an STD.
And we navigated the psychological traps of real-world patient misconceptions. We looked at how actively incorrect knowledge, the terrifying stuff we read on the open internet, creates a dangerous, sometimes life-threatening gap in care.
And finally, we arrived at the empowering solution, utilizing rigorous independent resources to master medication safety. We looked at how decoding drug databases, understanding the biological mechanism of fluoroquinolones, and dragging FDA black box warnings into the light can literally save your tendons, your nerves, and your agency as a patient.
It's all about agency. And as we wrap up, I want to bring it back directly to you, the listener. Knowledge, as we've explored today in excruciating detail, is really only valuable when it is understood and applied. The next time you face a medical assumption, whether it's an implicit judgment about a symptom you're experiencing, a diagnosis that just doesn't feel like it fits your life, or a new prescription you've just been handed across a pharmacy counter, I strongly encourage you to pause.
Just take a breath.
Right. Challenge the default narrative. Do not let societal stigma or the structural constraints of a rushed 15-minute clinic visit dictate your understanding of your own body. Use the verified, independent tools available to you to ask the right treatment questions.
So what does this all mean for the future? We spend this time unpacking how platforms like iMedix help decode medical mysteries and medication safety today using the data we currently have.
Right, the current landscape.
But consider this as you go about your week. As artificial intelligence and these massive, structured biochemical drug databases continue to merge, will the future of independent medical platforms become so advanced that they can predict your specific non-STD medical risks before you even feel a single symptom?
Oh, that's an interesting thought.
Right. If an AI knows your age, your prostate size, your weekend activity level, and your genetic collagen profile, could it warn you about a fluoroquinolone risk before the doctor even writes the script? Are we rapidly moving from an era of medical education to an incredible and perhaps slightly terrifying new era of highly personalized medical prediction?
It's definitely coming.
Something to think about. Until next time.